adalimumab. During COVID-19 pandemic era, Heathrow Healthcare, the pioneers in antivirals, offered Oseltamivir, Favipiravir, and Remdesivir to the patient, because of which in August 2020, they received an award of Pharma Excellence for COVID drugs. Today's webinar, role of Oseltamivir in flu management, we have got moderator Dr. Pramod Zog sir. Welcome Dr. Zog sir. The speakers Dr. Anil M.U. and Dr. Somashekar. Welcome Dr. Anil, welcome Dr. Somashekar.
Thank you.
Dr. Pramod Zog sir is Professor of Pediatrics, D.Y. Patil Medical College, Pune, President IIP 2016, Steering Committee Member GAVI CSO 2016 to 2019, Chairman Mini Recipe Module IIP, and author of the book Cophology. Once again, welcome Dr. Zog. Professor Dr. Somashekar A.R. Sir is Professor Ramaiah Medical College, Pediatric Pulmonologist and Adolescent Care Specialist, President IIP State Respiratory Chapter 2015-16, Treasurer IIP Allergy Chapter 2015, IIP State Allergy Chapter, Joint Secretary IIP Bangalore 2016, Secretary AHA 2016-17, EB Central IIP Respiratory Chapter, EB Central IIP 15 and 17, Secretary IIP State Allergy Chapter 2021, Chief Editor Pulmoscan, Executive Editor Journal of Pediatric Pulmonology, EB National Respiratory Chapter 2023, Secretary Environment Chapter of Child Health Group of IIP 2023-24, President IIP Bengaluru BPS 2024. Welcome, Dr. Somashekar. Dr. Anil M.U. sir is MBBS MD Pediatrics, Fellowship in Pediatric Critical Care and Diploma in Allergy and Asthma. Sir is lead consultant Pediatrics and Pediatric Critical Care, Sparsha Hospital, Bengaluru. Welcome, Dr. Anil. And with this brief introduction, I hand over the session to Dr. Pramod Zog. Over to you, sir.
Thank you. Okay. Just a second.
Yes, sir.
लेकिन बोलना प्रमोद हाँ उधर भी से बोलो ट्रेन का
Good afternoon, friends. So today we will be discussing an important topic related to influenza and the use of Oseltamivir in flu management. And I have my colleagues Dr. Somashekar and Dr. Anil from Bangalore to discuss this particular topic threadbare. As you all know, influenza is a virus, an RNA type of virus, which has created a lot of problem all over the world since 1918, because there have been 4 major pandemics. The one in 1918, which was erroneously known as Spanish flu, 1958, that was the Asian influenza, 1968, that was the Hong Kong influenza, and then 2009, which almost all of us have witnessed. These pandemics, they occur at an interval of 10 to 40 years, but in between, there are epidemics of influenza, and that is because this virus is an RNA virus, and these viruses are notorious to change their structures because of the change in the amino acid sequences very often. And that's why we have to even change the type of the vaccine every year. And the first slide that you can see shows Dr. Jog's name in the form of a nomenclature of an influenza virus, which depicts the place of origin, the month and the year of origin, and so on and so forth. So we will be discussing some of these aspects related to this disease, which is very common in the monsoon period. And these days also we are, rather fumbled by all those respiratory infections where we have RSV, influenza, and then rhinovirus and adenovirus and so on and so forth. And basically, till few years back, we were not much worried when someone used to say that it's a viral infection. But now the scenario is changing. The viral infections, they are coming with a lot of vengeance. And almost, after COVID, when we all of us had the immune debt, when people did not come out, they did not develop immunity against many of these viruses. And then after COVID, we saw the upsurge of viruses like hand, foot, mouth disease, RSV, and adeno, and some places where measles immunization was on the lower side, we saw the measles epidemics also. And all these are, to be remembered at the background of influenza, because influenza is one of the eminently treatable viral illness. Most of the other viruses, which are respiratory viruses, they do not have any particular antiviral against them, and very few antivirals are of clinical use in practice. Like we have antivirals for chickenpox, antivirals for CMV, and so on and so forth. So we are faced with recurrent RTIs, which are produced by these different viruses, and children, they have started going to school very early, and that's why they get exposed to other children coming from all the corners of the city or from the village, and that particular child gets frequent viral infections. And as I said earlier, even the older children are getting affected with different viruses. And that's why recently we had a confusing scenario where a 3-year-old boy who came with fever, cough, and cold and progressive breathlessness over 3 days with tachypnea, hypoxia, and presentation like ARDS, wherein we got this child admitted to the PICU, ventilated the child. The child received oseltamivir along with supportive therapy, and turned out to be H3N2 positive. He was ventilated for 3 days, and then he was all right. The main problem that we were discussing later on was, particularly when a previously healthy child comes with cough, cold, and fever, and progresses over 3 days, and then the clinician, after 3 days, starts some therapy like oseltamivir, whether the treating clinician can prevent this progression by starting antivirals early. And that's why there are some points which I say the points of confusion, related to flu, like, when a child comes with respiratory infection, whether it's bacterial or viral. If it's viral, what is the type of virus? If it is influenza, what is the type of influenza? And whether one should start oseltamivir upfront, and whether one should give antivirals to every patient in the epidemic scenario to play safe. And in monsoon, we are faced with influenza-like illnesses, which includes influenza. But influenza, I call, is the father of all the influenza-like illnesses, because it's the one which behaves like a systemic disease with a lot of headache, muscle pain, weakness, high fever. And we have seen children being lifted by their parents and brought to the OPDs simply because the child finds it difficult to walk or is extremely weak. And I'm sure everyone agrees that even after this influenza episode is over, there is a lot of weakness which persists. And this influenza is associated with a lot of morbidity and mortality over the last few years. And if you look at the KYC of this naughty virus, there are three types: influenza A, influenza B, and C. And type A is the one which produces frequent epidemics due to the minor antigenic variation in the glycoproteins on the outer surface, which are H and N. And I will tell you a bit more about it in a while. And there are periodic pandemics, which I told you in the beginning. These are due to major antigenic variation. In scientific terms, these are called as drifts and the shifts. Okay. And influenza B viruses, they infect only human beings. And that is why they produce only local epidemics. Basically, these viruses are found either in the birds or animals or in the human beings. And when these viruses from the birds or animals, they attack the human beings, later on, some of these, usually the pigs, they act as the mixing vessel where the virus from the birds and virus from the human beings mixes, and then a totally new virus comes, and that produces what is called as a pandemic. And that is something unique only for influenza A. So all those pandemics have been always related to influenza A, because it infects human beings as well as the animals. Influenza B doesn't affect the animals. And as I was telling you about this HA and NA, that is hemagglutinin and neuraminidase, these are the two glycoproteins, and they have a specific role. So hemagglutinin helps the virus to get attached to the respiratory epithelial cell, and the RNA within the virus enters into the respiratory epithelial cell. Inside the cell, it multiplies and produces many virions, and these virions are separated by neuraminidase, which acts as a molecular seizures and allows the exit of these virions outside the respiratory epithelial cell and these virions are then ready to infect other respiratory epithelial cells. So if you stop this particular exit of these virions from the respiratory epithelial cell by use of molecules like oseltamivir, which are neuraminidase inhibitors, then the further spread progression of the illness is halted. And that is why we have to start these molecules rather like oseltamivir a bit early in the course of illness, so that the release of the virions and the attack on other respiratory cells is prevented early. Okay, and that's why we will discuss all these issues in details in the next 40 to 50 minutes. And to begin the discussion, I will ask Dr. Anil to tell a bit more about the epidemiology and the circulating strains of influenza viruses in the pediatric population in India.
Yeah, thank you, sir. Thank you for that excellent introduction. I think you covered most of these aspects in your talk. See, when we talk about it, like sir told, there are two variants. One is a seasonal flu, which has been around, or the local epidemics which are caused, and a sudden shift that causes a pandemic. We see always this H1N1 is always written PDM09. PDM means it's the pandemic variety which was originating in 2009 pandemic. This was a H1N1 was the virus which originated there because of the sudden shift of these viruses. It was not a drift, it was a sudden shift. So no one had immunity, and so this virus spread like a pandemic. So H1N1 pandemic virus, which came in 2009, has now become endemic. So we are going through H1N1 all the time now. The other variety that we are getting currently, locally circulating strains, are H3N2 is going on right now. So both H1N1 and H3N2 belong to influenza A category. Whereas the influenza B viruses, yes, of course it is there. World over, the majority of the viruses which are documented are from H1N1, and then the H3N2 are being detected. And the other viruses are being detected at a much lesser frequency. So commonly, even in Bangalore, we are getting more of H3N2 at this point in time. In 2025 epidemic has been because of H3N2 variant. And also when I talk about the other lineages like Victoria and Yamagata, we were used to in influenza B, but currently we are not getting the Yamagata lineage. So only the Victoria lineage we are getting.
Okay. And Dr. Anil, what is your opinion about the viruses which are circulating in Bangalore?
Yeah, currently we are getting influenza, we are getting RSV, and adenoviruses are less. We had lots of adenoviruses 2 months prior, but right now the adenoviral epidemic has come down. So we're getting lots of RSV, and probably now the flu, which was there on #1 position last couple of months, has now come down to the second position, I should say. And many a times we are getting a co-infection also. RSV with flu has been the combination for us. RSV with the influenza A, that is a H3N2 variant, we are getting quite a bit, sir.
Okay. So this flu virus is basically the one which spreads to others, in a very, very highly contagious manner. And that is through the droplets when people speak or cough or sneeze. And these droplets land in the mouth or the nose of the people, and then it starts spreading itself. So Dr. Somashekar, would you just like to elaborate a bit more about the clinical presenting features of children coming to your OPD with influenza?
See, this present epidemic is there, and what we are seeing is majority is like mixed infection, RSV or influenza-like illness. That's we all treat like any common coryza, cough, cold. When it comes to particularly influenza-like illness, what the character feature is, by third day they'll become sick. They'll become excessive tired, disproportionate to the illness. They'll have some GI symptoms like vomiting or diarrhea, torrential headache, and other things. These are the common symptoms. By third day, your common complaints, common URA becomes little more sick. That is the time you suspect influenza-like illness. That is one thing. Another thing, what case scenario we have seen is one is like 2-3 cases of bronchiolitis we have seen admitted and came positive. A case of pneumonia. Now it has got a double infection. It has gone to the level of doing VADS also. Severe pneumonia with the influenza being PCR being positive. That is also there. And another case of a nephrotic syndrome recently detected, got H1N1 and went into shock, revived. All these things are there. These are the common scenario. And the important thing is we are getting a lot of febrile conversion. 2-3 presented as a febrile encephalopathy recovered. And these are the common case scenario where they had been treated or evaluated at the OPD or the eye dependence area or the ICU. Other things, what we have seen, immunocompromised state also, we should be careful. Those who got asthmatic patients, those who are diabetic, obesity, immunocompromised, they are the one where they are susceptible for this influenza or influenza-like illness, where they present characteristically behave like influenza with a lot of complication. That should be little more concerned. Otherwise, majority self-limiting, and we should be cautious of progressive illness, and those who are landed in eye dependence area, treat them adequately with high index of suspicion.
And then, of course, related to the presentations with complications, I will come back to Dr. Anil little later in the course of the discussion. So, as of now, we must remember that there are illnesses which affect the respiratory system, like the influenza-like illnesses, H1N1, severe acute respiratory infections, COVID-19, which have their own specific points, just as we know that the loss of the smell and the loss of the taste were commonly described during the COVID pandemic. Similarly, as we said earlier, a child who comes with severe headache and weakness and pain, usually, we suspect influenza. So all these viruses there are some features which are, specific to them. But in general, it's very difficult to differentiate one virus from the other. And that's why we have to be, very, very alert about the emergency warning signs, because we do not want some of these illnesses to progress to seriousness. So, Dr. Anil, would you like to elaborate a bit more about the emergency warning signs of flu illness?
Yes, sir. I think we should be very careful about these red flags. Like sir told, day one, day two, it may just be a viral kind of an prodrome or a viral kind of illness, respiratory illness. Child may still be active and playful in between the interfebrile period, may have a little fever, headache, cough, sore throat, these kind of symptoms. But always we should counsel the parents about these red flags. The most important information is we get it by observing the child in the interfebrile period. Is the child active, playful, and accepting feeds in the interfebrile period? That's the most important one. If at all the child is becoming dull, lethargic, child has got an inability to feed, or system wise, when we start looking at it, respiratory system wise, if the child starts developing any kind of tachypnea, breathlessness, incessant bouts of cough, which is not at all stopping, or starts becoming drowsy. CNS wise, if you look at it, the child will start becoming little lethargic, drowsy, or in the height of fever, the child may have other complications like a febrile seizure or other things. Or if there is a multi-system involvement, these are the red flags that we need to look at. Most important is the ability to feed and how is the child doing in the interfebrile period.
Sure. So we all should be aware of the complications of flu. Most of them, they start with the alphabet A, wherein flu can complicate as acute respiratory infection in the form of pneumonia or ARDS. It can lead to acute otitis media, or it can lead to school absenteeism. And as our pediatric colleagues are confused about the presentation, whether it's viral or bacterial in certain situations, it may lead to some antibiotic abuse. So coming to the treatment of influenza, Dr. Somashekar, we are all aware of the categories A, B, and C, though we will, revise them in a while. And that's why it is important that we know the management about, these regard to all these categories. So will you just elaborate a bit more about these?
See, yeah, it is very important. Why this is important for to know what are the clinical characteristics. Another thing is for the management, this categorization of ABC is important. When it comes to A, it is more of simple, like any common presentation like cough, cold, coryza, with little characteristics of influenza-like illness. They'll have fever, cough, cold, or presentation like headache, vomiting, and diarrhea. But the category B is the one where you should be little aware that is the high risk and severe symptom. This includes category A symptoms as well as the little more symptom like high grade fever, severe throat. As well as the here important thing is they comes under Less than 5 years or especially less than 2 years, they comes to category pre, and as well as pregnant women, the elderly people more than 65 years, or with comorbid conditions like chronic lung diseases, or cardiac issues, or liver issues, or kidney, or any chronic vessel disorder, and diabetic, uncontrolled diabetic, progressive or controlled neurological disorder, or the retroviral disease. There are the one comes to, or patients with on high-end steroids or long-term cortisone, they comes under category B. That's okay. You understood. Both are relatively, that is mild is category A. B is the where we should be more compromised, immunocompromised state. We should alert these children or these patients are, they're susceptible to the progressive illness. But category C is the where they'll have symptoms, progressive symptom or acute symptom like severe breathlessness, chest pain, drowsiness, important hypotension or blood in the sputum. And mainly their decreased activity, persistent vomiting, diarrhea, difficulty with these are all the cardinal symptoms of category C. This category A, B, C will be helpful for our management and to categorize are the proper triaging of the condition.
Yeah, it's very good. Now, Dr. Anil, we will be discussing a bit more about the antivirals in a minute. But just before that, would you just revise what Dr. Somashekar said about the management in the form of category-wise management?
Yes, sir. Category A are the simple OPD patients who are still active and taking orally well. So just simple management, OPD-based management of home isolation, supportive care of making sure they're having enough amount of fluids and giving paracetamol for the symptom relief is sufficient for this thing. We should carefully advise them on isolating from others, and especially the high-risk contacts who may be at home, better to be isolated. So that is enough. In category B, these are the moderately sick ones who would require hospitalization. And of course, category C, who are extremely sick, who will definitely require even HDU or even an ICU kind of a admission. These categories, we need to start them on antiviral. And also all the supportive care needs to be continued in category B and category C.
So now we will just have a look at this molecule oseltamivir, and that's a neuraminidase inhibitor. And we all know now that neuraminidase inhibitors block the viral neuraminidase enzyme, which is critical in releasing the virions from the infected host cells. Remember that this particular enzyme is very specific for influenza virus, and it is not seen in other respiratory viruses. None of other viruses contains this neuraminidase, and that's why it is important to use this very specifically for children suffering from influenza. And when you're using it empirically, it is essential that you should use it with a lot of clinical suspicion and proper categorization. Of course, this particular molecule is a potent and a selective inhibitor of neuraminidase enzyme of the influenza virus, and it's a prodrug which is converted to the active form, and then it inhibits the influenza virus replication and pathogenicity, and it prevents further spread of infection. And this is the diagrammatic representation as to how it blocks the release of the new virions. And this was the first oral neuraminidase inhibitor which is approved in more than 100 countries, and it has been approved by CDC and American Academy of Pediatrics. So we have seen the management protocol, and now we will just have a look at the dosage and the recommendations. So in adults, the therapeutic dose is 75 milligrams twice daily, and the prophylactic chemoprophylactic dose is 75 milligrams once a day for 10 days. The therapeutic dose in adults as well as children is for 5 days, while chemoprophylaxis is given for 10 days. Therapeutic dose is given in twice daily dosing, and chemoprophylaxis is given in a once daily dosing form. For children, the dosage depends on the weight bands from infancy to beyond 40 kg, and the dose in infants is 3 mg per kg twice daily. That is the therapeutic dose, and then it starts from 60 to 90 to 120 to 150 milligrams per day and divided into 2 doses, while the chemoprophylactic dose is from 30 milligrams onwards up to 75 milligrams once daily. And this particular drug is available in syrup form also. So, Dr. Anil, how does early initiation of oseltamivir influence the management of influenza?
Yes, sir. The various studies have shown us that early initiation, as early as 48 hours or even before that, reduces the duration of the flu by 24 to 48 hours. It reduces. And also, more importantly, what it does is it prevents the progression of the symptoms. As we know, viral illnesses are multi-system illnesses, and if left untreated, sometimes they may overcome the immune system of the host to cause a multi-system disorder also. So by initiating early, we are making sure that the person is symptom free much before 1 to 2 days of reduction. It's statistically kind of significant, and also it prevents the complication also. But again, telling that it should be started before 48 hours, we have many a times for patients who present to us on day 4 and day 5 also, who are pretty sick and who are progressively becoming sicker. So in such situations, we should not hold it back telling that it's a self-limiting illness. If someone is becoming as sick that they're requiring to be admitted as inpatient, I think even on day 4, day 5, this can be started, and this can prevent further progression and complications also.
Thank you. So let us see certain clinical trials which have shown the benefit of the empiric and the early use of oseltamivir. And these patients with influenza have shown that oseltamivir reduces the antibiotic use by 26.7% and the influenza related low respiratory complications and the hospitalization. And all these findings have been in children as well as in adults. So, Dr. Somashekar, what is your opinion about the use of oseltamivir, whether you should start it empirically on clinical suspicion of influenza or whether one should wait for certain investigations like the nasopharyngeal swab?
See, you should be rational in starting empirically. Okay, just because just any cold for cold, we can't start because we are also worried about resistance. Very good paper is there now. Yesterday also you also depicted that we can start empirically. But if there is a high index of suspicion, if the progressive symptoms, take the swab and start the whatever the medication. You can start oseltamivir. Otherwise, if you are thinking like, one patient is exposed already in the family, if there is a young baby or extreme age, 65 years old, or any immunocompromised state is there, please start. So you can start empirically in those conditions rather than it should not be a blanket treatment. That's what I say.
Okay. So the guideline recommendations from WHO, they say that empiric treatment is strongly recommended and the treatment should be started as soon as possible, and the laboratory confirmation of influenza virus infection is not necessary for the initiation of therapy, and the negative laboratory test for H1N1 does not exclude the diagnosis in all the patients, and therefore you have to start it early. And the early empiric supportive therapy and monitoring is very, very important in children with influenza. So we will now have a look at a few cases and clarify certain doubts related to the management. Dr. Anil, this is a child who has come to us with fever for 3 days and cold and cough. He has been on metered dose inhaler since 4 months. He is well controlled. He has received symptomatic treatment, and after 3 days, he comes back. And right now, he has again developed fever. In between, he was afebrile. He was also active in between. So these are the situations which we commonly face in the practice. So these are the children with recurrent viral upper respiratory infections which have become more frequent and they come at shorter intervals. So how would you counsel such parents? What treatment would you give to such parents?
Yes, sir. This is the common scenario I think all of us pediatricians come through in our daily practice. Almost every other patient has become like this now. Children are coming to us with recurrent virals, cold, coughs, and all that. Our role in such a situation would be to examine the child, make sure that there is nothing more sinister going on, and reassure the parents that there is nothing much happening. But some of the parents become highly anxious because of the current scenario, current media reports, and all that. So they may pressurize us for antibiotics or further investigation or further higher end treatment, which may not be required in all these patients. A thorough systemic examination and counseling the parents, telling that this is looking like one more viral infection, will also delineate the why these viral infections are happening, because the child is getting exposed to other children at school, or this is just about the age group where their immunity is learning about all these new viruses that they're coming across. Also, like Pramod sir says, always it should be growth chart based counseling. Always we should plot the growth chart on the of the child on the chart to show that the child is growing absolutely fine. So there is no major concern about the health apart from these minor cold cause, probably which will become the fourth member of your family for few years till the child grows up. We need to adjust with this mild cold or the nasal congestion that is happening. At the same time, we'll assure them we'll have a relook. If at all there is anything wrong happening, please do visit me in 24 to 48 hours. You can come back and we will have a relook again. Like that, we can counsel this patient.
So, one should always tell the parents that these recurrent viral infections are a part of growing, and 8 to 10 viral upper respiratory infections in a properly growing child are normal and one should not be worried about. Sometimes I tell the parents that when the child develops viral infections, he is developing the immunity against that virus, and in a way it is better. So I tell them that just look at this viral infection in a positive manner. So when they say the child has cold and cough, I tell them, see, don't be worried. The child doesn't have fever. No, they say, no, fever is not there. So then I tell them it is better. If fever would have been there, that would have been a different situation. I also tell them that look at it positively, that the child is developing immunity against that virus while he is growing. So the parents are, counseled to some extent. And then, Dr. Somashekar, do you have any additional tips for the parents?
No,
Rather, tips?
just ask them to get the previous records. You are shown, like, previously, like, previous episode, they recovered well, there's no issues. So we'll treat like this only. In future, any, like Dr. Anil said, any further progression of the symptom, then we'll add the antibiotic that we can do. And majority, these are the new patients, they'll be little conscious about this antibiotic. Just speak to them, reassure them. I think they'll become old enough by a week or later.
Yeah. I think this is an important part of our practice because to prescribe antibiotics reflexly without much of the thought process, is relatively easier. But then to counsel takes little time, and that's why you must spend a bit more when you speak to such parents. Otherwise, we will never be able to control the antibiotic abuse. So it's also important to know some clinical clues to the viral and bacterial infections which attack the respiratory system. So rhinoviruses, as we all know, they produce common cold. They affect the upper airway when there is either mild or no fever, and the child is not exhausted and is playing well. And they come with cold and sneezing. Along with high fever, when there is prominent headache, myalgia, and extreme exhaustion, we should suspect flu. Whenever the child has pharyngoconjunctival fever, diarrhea, mesenteric lymphadenitis, hemorrhagic cystitis, one can suspect adenovirus. And in a child less than 1 year, we should remember that RSV can produce bronchiolitis. Bacteria, yes, bacteria will produce different sort of presentations. So group A beta hemolytic streptococcus will produce fever, follicular tonsillitis, and tender cervical nodes. Pneumococcus will produce fever, grunting, and tachypnea. And staphylococcus will produce rapid progression and the child will be toxic. Mycoplasma will affect little older children and predominantly will present with cough. When you look at the x-rays of a child who has viral infection, the child will not be sick, but it is said that the x-ray is sicker than the child. While in case of bacterial infections, the child is sick as well as the x-ray is also sick. And this is a 4-year-old child who came with cough, fever, and fever of high grade since 5 days. He was not settling with oral medicines. On admission, he had tachypnea, needed oxygen support, and his total count was 1620, platelet count was 132,000, SGPT 381, SGOT 168, nasopharyngeal swab was positive for H3N2, and then he was diagnosed as a child of influenza with low WBC count and low platelet count. So Dr. Anil, how would you analyze this particular case so that our colleagues would know the proper approach to such a case?
Yes, sir. This child, when the child presents to us, we may not have the X-ray or the investigation. So when we look at the child either in the emergency room or in our OPD, this straight away, if the child is already tachypneic, requiring oxygen support, saturations are low, this would straight away be our category C kind of a patient. So according to our category C, if we even work by without any diagnostic resources, so the category C would require immediate hospitalization, immediately providing the supportive care. We would draw appropriate cultures and start this child on IV antibiotic, and probably because of the epidemic of flu that is still going on, this child very well deserves to be started on empirical oseltamivir therapy here, with or without the swab testing. If it's available, yes, well and good, we go ahead and send for the swab also. But this child needs to be on both antibiotic and antiviral agent. And now, once the labs are back, we look at it. There is a significant leukopenia, platelets are on the lesser side. There is a little bit of transaminitis. So again, there is, and the X-ray has come back, which shows us there are infiltrates on the right side. So again, this tells us this is a multisystemic kind of an involvement, and with the counts being on the lesser side, most probably it's a viral kind of illness. So till the blood culture comes back, till the swab comes back, we would continue on both antibiotic and the antiviral agent for this child. And once the swab comes back, and here looking at the transaminases, I would just want one more investigation. Our old friend dengue, we should not be forgetting. So dengue needs to be screened for any coexisting infection. Even though it's a vector-borne disease and the mode of transmission is totally different, in this epidemic, especially post-monsoons, I think we need to screen for dengue also. And of course, once the swab is back, it makes the picture very clear. This is a viral respiratory illnesses, and we can be confident and stop the antibiotics and continue with the definitive therapy for the flu. That is the oseltamivir can be continued later on.
As Dr. Anil said, we had both dengue being positive as well as influenza. Both were.
Oh, okay. Dr. Somashekar, we also saw certain cases like these where there was cough and fever for 5 days. The fever was not settling, but the counts were normal and the throat swab showed S3N2. Again, another child where there was cough, cold, and fever. The counts were normal, but the CRP was 38 and the nasopharyngeal swab showed S3N2. So, just wanted to know your opinion about the factors on which clinical response to oseltamivir depend.
See, very important. We have mentioned when we are starting the medication, like less than 2 years, more than 5 years, high index association, severity of the symptoms, comorbid condition, we are categorized by A, B, C. That's important. We have started. I think empirically we are justified and judicially starting it here also. But the clinical response, the baby's activity will improve first and foremost, because they'll become excessive, disproportionate tiredness that will be there, their fever will come down, their respiratory symptoms will be there. And in the high dependency area, your requirement of oxygen will come down, work of breathing comes down, and the temperature comes down, the markers comes down. These are all the clinical response when you start as early as the oseltamivir in a patient with high index of suspension, influenza or influenza-like illness.
So you want to convey that oseltamivir, when started early, it would give better results.
Better outcome.
So yeah. Of course, this particular child, 4-year-old, we got him with cough and cold for 5 days, but the counts were high and the CRP was 136, and the child had continuous high fever, and the nasopharyngeal swab demonstrated adenovirus positivity. Dr. Anil, this is a 5-year-old girl, came with high fever for 5 days, cough and cold for 5 days. And when she came, she was sick looking. She had mild wheeze, but there were no crepitations. So, what will you do for this child? Will you put this girl on antibiotics?
Yes, sir. This child is 5-year-old child. Already 5 days of illness is already over, and the child is still progressively becoming sicker. And also with the with the wheeze which is developing, and if it were to be a simple viral illness, we would have expected an improving trend by already on the 5th day. Since it's not improving, this child deserves to be admitted and probably started on IV antibiotics also after taking the appropriate cultures.
So accordingly, this child was put on IV amoxiclav. The WBC count was 2800, the neutrophils 10, lymphocytes 70, CRP was 34.7, and this child was also put on oseltamivir, and the nasopharyngeal swab showed rhinovirus. So I have just two quick questions for you. One is that when a swab shows something different, not influenza, but a rhinovirus? How do we look at it? And then, what is your opinion about the sensitivity of this influenza PCR and the further treatment decisions?
Yes, sir. The latest generation of PCRs have a very good sensitivity and a specificity for detection of influenza. What WHO says is the latest PCRs have a sensitivity of 95% and much higher specificity also, even close to 100% specificity in ruling out influenza. So what the WHO says, if the swab is negative, we think we go ahead and stop the treatment with the oseltamivir is what the WHO says. But we as clinicians, we should have a working diagnosis. Even before we send out a swab, we need to think what is if it's a viral respiratory kind of a syndrome, that is when we send a swab and start them on oseltamivir. Many a times there may be 2-3 different scenarios. Number one, where none of the viruses, common viruses, will turn up positive. That means that there is no other alternative explanation for this child's present illness. Clinically, we are strongly in favor of a flu-like illness. Especially in this epidemic, we are on strongly thinking about influenza. So in such situations, I think we are justified in continuing the treatment and completing the treatment of 5 days. And the second situation where an unrelated virus may turn up. It may be a rhinovirus, it may be adenovirus, it may be RSV. When we are doing a multiplex PCR, these are the other viruses which will turn up. And we get a good enough explanation like an RSV and the flu is negative, or a adeno and the flu is negative. And I think safely in such situations, we can go ahead and stop the oseltamivir and continue to treat. So if there is no other alternative explanation, we should, and the viral syndrome is of a respiratory viral syndrome, we need to continue with the therapy and complete 5 days. And if you get any alternative diagnosis, like a child developing a tonsillar focus or a respiratory lobar kind of a focus, we need to continue on a IV antibiotics. So I think this is my take on the influenza swab positivity and the treatment decisions which will come along with it.
Sure. So now, Dr. Somashekar, this is a 7-year-old daughter of IT sector parents, and she has high fever for 3 days. The parents are worried because the child also has throat irritation. There is a lot of flu and adenovirus around, and she has exam 2 days later, and they have come to you. When you examine, you find that the throat is mildly congested, and you feel that the girl probably only requires paracetamol. But then the parents are from IT sector, and I always feel that IT is also equal to inquisitiveness and a bit of a troublesome behavior. But then with that, how do you manage such children and such parents?
The important thing is here, just it is of 3 days. Can you go back to the slide? Yeah, 7 years old, 3 days, and only the issue is more than the symptoms. Exams are parents are little worried rather. So we'll wait for 3 days. It's like common symptoms are common viruses are going on, bacterial infections are there. This is the season, winter season is mainly for this respiratory. We'll just monitor the symptom, tell about the dangerous signs, red flag signs, or the indication of antibiotic later. That's important. But if you are thinking of strong suspicion, if somebody in the family has got H1N being positive or baby being exposed, you can start empiric Oseltamivir. Otherwise, just wait and watch policy. It's always better.
So if I get you right, this child really doesn't need anything, and being in category 1 even for influenza, even doesn't need throat
Yeah.
swab as well as
Yes.
oseltamivir, isn't it? Right. Dr. Anil, this is a 3-year-old boy who has come with cough for a week, high fever for 3 days with crepitations, and he has been put on co-amoxiclav and admitted for persistent fever, has been put on IV augmentin, and while on therapy, the swab has come influenza A positive, and that's why oseltamivir has been added. So now the question is whether I stop the amoxiclav that has been started or whether I continue. And of course, this you can just answer in the light of another fact that sometimes the child is receiving an antiviral, and then he rather continues to be sicker in spite of the antiviral. So whether we should add antibiotics. So what are the different situations which would be faced by our colleagues?
Yes, sir. This in the light of antimicrobial stewardship, I think we should be careful in such a scenario. So when the other labs are also supportive, the CRP is negative, that counts are more like a viral kind of a picture. There is an epidemic of flu that is going around. I think we are prudent in stopping the IV antibiotics if the flu turns out to be influenza A positive. Influenza A or B, if it comes positive, it's okay to stop the other antivirals, provided that the child is getting better in the first 48 hours after starting treatment. There is reduction in the overall wellness of the child is improving. The fever spikes are improving. It is okay. But if there is an improvement and then again a sudden deterioration, say we are only on the antiviral agent like Oseltamivir, and say after 48 hours the child is becoming more sicker, the respiratory distress is not getting better, and if at all we are having labs, we can always repeat it in the next 48 hours to see if the CRPs are rising, and if there is a low bar kind of a consolidation that is starting, then this is the situation where we need to start on IV antibiotics also, because the literature says up to 10% of the children can have a coexisting uh, bacterial infection also in the respiratory tract. So in such situations where we are only on oseltamivir, antibiotics also will be indicated.
Right. Streptococcus pneumoniae and Staphylococcus, these are the two bacteria which are known to produce secondary bacterial infection. But it's important that we remember this antibiotic stewardship. And that's why if the PCR is positive, then either one should not add, or if at all the situations permit, you stop the antibiotic, but at least do not escalate to something different. Okay. In our practice, we have seen quite a few cases which came with involvement of the CNS and were diagnosed as a case of influenza encephalitis. For example, this 1-year-old with fever, cough, cold, and came with status epilepticus, and it turned out to be H3N2 positive, and the MRI showed non-specific changes of encephalitis. The CSF was normal. So, Dr. Anil, as an intensivist, I would request you to elaborate a bit more about the neurological involvement in children with influenza.
Yes, sir. After this respiratory system, the second most commonly affected system is the CNS. The spectrum varies. It can be a simple febrile seizure, and sometimes because of the high-grade fevers, they may have a repeated episodes of fever-triggered seizures, which may go on for a longer time. Some children, we are seeing that, especially little older children, because of the high-grade fever on day 1, day 2 itself, they're landing up with encephalopathy, or they become delirious during the high grades of fever. They become little delirious, or they may become encephalopathic. This season, we witnessed a child with acute necrotizing encephalopathy also. Child who had a family also have members also had this febrile kind of illness, and this child coming from a rural background, probably they didn't have access to oseltamivir, which was not started. So after 48 hours, this child presented to us with very high grade fevers and multiple episodes of seizures. Following that, the child had become comatose, and the MRI, which was showing like a typical JE kind of a feature where bilateral thalami were lighting up, and there were areas of necrosis also which were there. And we promptly, in these situations, we can't demonstrate a virus from the CSF because it's an immune phenomena which is going on. So the virus still has to be demonstrated from the respiratory tract. We did a LP which showed no cellular response, but the nasopharyngeal secretions can be sent around, which can corroborate if there is a positivity in the nasopharynx. That is, findings are taken to be corroborative and causative agent for the CNS insult which is going on. So we have had all such things, and especially with the influenza B illness, we get lots of myalgia, muscular weakness, almost a GBS kind of a situation also. So they may have extreme pain, inability to walk, which may go on for a week to 10 days. We have seen that happening. Doing a nerve conduction study kind of differentiates between the neuropathy or a myopathy. We are able to take a call. If the nerve potentials are preserved, we are okay in just treating, hydrating the child and giving them analgesics and rest, good amount of bed rest, which will cure their myopathy that is happening. And very rarely literature, we have seen that there have been renal involvement and a hepatic involvement or a progression into MODS also. It's been described. We don't see that very commonly in our practice.
With that, we
These
also
complications we have seen, but early initiation has made all the difference, Anil, right?
Yes, sir. Yes, sir.
Yeah.
Yes.
But even though they are like sick, but that's okay.
yeah, that's fine. We also have seen influenza with RSV in different forms. and that also needs to be managed in a particular way, so that we are not likely to land in any trouble. And we all are aware of the respiratory complications, which we already discussed, like otitis media, the primary viral pneumonia, which is common in a child with underlying risk factors, those who are under the age of 2 years. And as we discussed, these children, usually the secondary infection occurs with Streptococcus pneumoniae or Staph aureus, and there have been children who had toxic shock syndrome, myocarditis, myositis, which Dr. Anil just elaborated, which is more with influenza B, where bilateral involvement of gastrocnemius and soleus is known, and hepatic complications like the Reye syndrome in children of influenza B who receive salicylates. So it is important that we avoid, rather not use salicylates for the control of fever or muscle pain in children where we suspect influenza. And we have certain questions, quick questions. We have already discussed some of these points, but then Dr. Somashekar, if a child gets admitted on day 4 of illness with LRTI and child comes influenza A positive, it's already beyond 48 hours. But in this case, shall we start oseltamivir, and up to what day of illness will this molecule be effective?
You're muted, sir. You're muted.
Ideally, better to start by 24 to 48 hours. But whatever the reason, you can start at any day, like fourth, fifth, or sixth day. There'll be definitely the good papers have shown that the best outcome of the or mean duration of stay has come down. But what happens here also, whatever the clinical progression may be there, but it halts the progression by reducing the viral shedding. That's where our viral load comes down, whatever the day you start. Early the better is always good, but even on the fourth or fifth day, you can start the.
Okay. Dr. Anil, there are two brothers in the same family. The elder one is a sibling of 8-month-old child, and the elder one is admitted with influenza A for LRTI. And the 8-month-old child develops fever. So what do we do? Shall we start oseltamivir for the younger one?
Yes, sir. In such a situation, I think empirically we can go ahead and treat, not just on the prophylaxis. If they're symptomatic, we go ahead and treat the other sibling also, because we know that the respiratory viral shedding happens one day before the onset of symptoms to up to 5 to 7 days after the onset of symptoms. So probably if one is proven, I think that is good enough evidence to start the other one on empirical oseltamivir.
Right. Dr. Somashekar, if the child is not accepting the oral medicines, is there any alternative?
See, there's no alternative for this. Have patience and tell the parents also have patience and tell them how to orally feed. Small intermittent feeding definitely helps.
Okay. And Dr. Anil, what is the role of chemoprophylaxis in the family members?
Yes, sir. It's indicated, but again, we should remember not for everyone. If there is a healthy adult who is there, 40-year-old father, 40-year-old mother with no comorbidities, we need not actually start them on chemoprophylaxis. Prophylaxis is required for the category B high risk people who what we discussed. If we have a extremes of age group, less than 2-year-old or more than 65-year-old, or they have other comorbidities like a diabetes, hypertension, they have a cardiac issue, they have a chronic lung issue, they are on chemotherapy for whatever other secondary malignancies, or for whatever reason, if their immunity is suppressed, they're on long-term steroids. These are the people who needs to be on prophylaxis, not the healthy ones.
Right. So maybe our colleagues can remember that when they prescribe oseltamivir for children, proactively they should inquire whether there is anyone with risk factors in the family. For example, a grandfather who is asthmatic, or a father who is diabetic, or someone who is on long-term steroid therapy. So that, proactively, if you inquire, then you can also request the parents to start chemoprophylaxis for those high-risk members in the family. And then, Dr. Somashekar, whether high-grade fever, severe sore throat with cough and cold, whether it's an indication for starting oseltamivir in the current situation?
So high-grade fever, this is the epidemic where we got other viruses also. All the virus present like high fever. But as we mentioned repeatedly, with high index of suspicion, if there is an exposure in the family, you start. Otherwise, there is no indication of starting oseltamivir in the current situation.
Okay.
Unless you have a high index of suspicion.
Okay. And Dr. Anil, what is your opinion about oseltamivir, whether it works on parainfluenza viruses?
No, sir. Para-influenza has influenza in the name, but here oseltamivir doesn't work. Para-influenza viruses typically happen in our small babies, like 1 year old, 1.5 year old babies. They typically come with a high-grade fever and a croup kind of a situation where I think our management of croup or a definite supportive care is all that is required.
Right. Till now we have seen lot many points related to this particular illness, and we have seen ABC of influenza. That means the types A, B, and C. We have seen the categorization into A, B, and C, and our panelists also have been ABC, accurate, brief, and clear in their disposition. And I must say that we have to remember A, that is assess and decide the need for antivirals and antibiotics. B, beware of the danger signs. And C, consult the pediatrician if required. Remember that the virus is fast and furious with abrupt onset, high transmissibility, rapid progression, even to ARDS. And that's why we also have to be very quick in starting oseltamivir. We also should remember that there are preventive measures in the form of sanitization, mask, social distancing, which we learned during COVID pandemic. Cough etiquettes, one should remember to cough in the elbow. And also remember the Hasta Pancha Sutri. These are the 5 sutras related to the hand. Wash the hands frequently, particularly we as medicos must wash the hands repeatedly so that we avoid the fomite transmission. Avoid handshake, use handkerchief, also keep others at a hand's distance, and also avoid hand touching. Also remember to have flu vaccine. Particularly this is important for the medical fraternity and the staff in the hospital because we are the ones who are maximally exposed to the patients of influenza. And everyone is aware that children directly cough onto our faces when we examine their throats, and that's why we have to wear mask and be very, very careful. And that's why I always say that it's happy birthday to you. In addition, we have happy birthday to flu. So once in a year, please see that you receive the latest influenza vaccine which is available. So with that, I thank our listeners and say namaste. And that should be the way to rather greet and say goodbye, because that will also avoid the transmission of the virus from one person to other. Thank you for a patient listening, and I hand over the proceedings to the hetero pharma, Dr. Prashant.
Thank you, sir. As usual, very interesting and very insightful. Every time I get new, today's ABC was excellent, I must say. And thanks, Dr. Somashekar. Thanks, Dr. Anil. I mean, we are excellent. I'm enjoying
Thank you,
personally,
sir.
although I'm
Thank
not a clinician, I'm still enjoying. I feel that I can diagnose without any investigation also. Thank you so much for these insights. Thanks, Hetero team. Thanks, the sales team. Thanks, marketing. Thanks, Nagadevi. And we can sign off, sir. Thank you so much.
Thank you, sir.
Thank you.
I wish you a
Thank you,
pleasant
sir.
evening.
Thank you.
Thank you.
Thank you, Pramod sir. Thank you, Aril.
Thank you.
Thank you,
Thank you
sir.
all.
Thank you, sir. Bye. Bye.